Hello everyone, together we are again back with a new video. Dear John McNally will inform us about some important questions. So my question would be, what should we expect from the first session of psychotherapy?
This is a good question because if you're just coming into therapy for the first time, you don't know what's going to happen. The first session, obviously depending on who you go and see, what therapy to go to, will determine what happens in the first session. The most common feature of a first session comes in basically three parts. The first part is an assessment to figure out what's going on. I'm going to go through in a second, I'll go through what happens if you were to come to see me, because everybody's a bit different. The next part of that will be, following the assessment will come the diagnosis so that I can understand it. And the third part will begin the treatment of the actual diagnosis. So three parts, basically, the assessment, diagnosis, and if there's time left, to start the treatment. So with me, if you come in to see me, what you need to know is I start treatment and assessment all in one. So I'm always in the process of figuring out what the problem is and treating it every time you come to see me, no matter where we are in the conversation. When you come into my office, you're going to sit, you'll look around. We'll start with some very basic questions, and then I'm going to ask you, just tell me what's going on. Tell me what you are thinking about and why you wanted to come to see me. Most people feel a bit shy about this question. They don't know where to start, but that for me is actually very telling because they're going to start somewhere, and that where they start actually starts to inform me about how they see their own problem. And that's really the information I'm looking for. I will use questions to then maneuver the conversation into areas I need to look at. So I will look at what your work is, whether you're still going to school, what your education level is, what your childhood was like, what your social life is like. I'm going to start to maneuver questions in and out of this all the time. I'm looking for specific details, which I will write down, so I take notes. I'll write down specific details about what's going on. But I'm also assessing the way in which you are answering the questions. So I'm always in the process of looking at the higher structure of the language you're using, because I'm going to use that frame of reference to apply it to the therapy later on. For example, if you start describing your childhood in terms of this great flowery presentation about stuff and how great it was and everything else, and you're coming to see me with depression, I'm going to notice the difference in whether you can express happiness in this moment that you're also feeling depression. Do you see the difference? It's not just what you're telling me about your childhood, it's also what's happening in the room as you do it. And I'm going to watch the words you use to select to use to describe things. If you can only describe things in terms of negative presentation, it tells me something about how your brain is working in this moment. So I'm going to look at all those different parts of your childhood, education, how you interact socially with others, whether or not, so typically depressed people, their whole system is designed around not burning up energy. They're going to pull away from social interactions, so they're not going to be out going to parties typically. They're going to be withdrawing. They will either, if they have to go to parties, they will withdraw emotionally, so they'll only superficially be there. So I'm going to be looking at all these different ways of how the person presents, but equally how they're presenting in the room with me as I'm talking to them. I'm going to ask questions about addiction issues. So I'm going to ask whether you're taking any recreational drugs, what medication you're on, if you're on any medication from your doctor, and also your medical history to see if there's anything there that may be causing, say, a diffuse pain in your back, where that might be coming from, if it's an actual physical problem or whether there's a psychological basis to it. I'm going to be looking at and asking questions around whether you drink, how much alcohol you drink, how much you consume in a week. I'm going to try to build a picture of what's going on in your world, because I'm going to use this very picture to determine what areas I have to address first and what areas I can leave for later. So even though depression may be what's presented, if you have an addiction problems with the depression, the addiction actually needs to be treated first. If you're telling me you're drinking 15 beer a day, yeah, well, believe me, there are some that do. If that's how you're going to what you tell me, then I already know that this guy, the drinking problem, is related to the depression problem. That is, they're working together now. So I'm going to address the drinking problem first, and then I'll go, if the depression's still there, then I'll go after that. I'm also going to talk about suicidal risk. We talked about briefly about that before. I'm going to ask whether you have suicidal thoughts, whether you've actually made an attempt. If you have suicidal thoughts, I'm going to break that down to understand how you're doing that, when it comes up, if it happens at a certain time of day, if it happens only on weekends, if it only happens when you're drinking. I'm going to try to tear apart sort of the picture of it so I can understand the details of it. If you've moved from, say, thinking about hanging yourself to going out and finding a place where you're going to hang yourself, a tree somewhere, or buying the rope to hang yourself, then this type of stuff gets me more interested because the risk increases with the more you move from thoughts to behavior. So I'm going to get a lot more concerned about that, and I will probe that even further. So I'm going to probe whether you're hearing voices or you're seeing things that other people don't see. This is a basic psychosis question. The reason we have to do that is because you may be presenting with depression, but you may also be hearing voices. That has ramifications in terms of how I'm about to treat this. This would be referral into a psychiatrist to get antipsychotic medication so we can control the voices in order to get at the depression. As I'm talking to you, I'm going to ask questions, and those questions can be framed in one of two ways. They're called open and close-ended questions. Open-ended questions tend to be like, can you explain what you mean by this? And you can see how I just leave that for you to sort of fill in whatever you want. When you have an open-ended question, people will tend to move towards an emotional expression, so they'll start telling me how they feel. On the other hand, a close-ended question
Yes, no.
will be yes, no, or I'll say, you said when you were a child you lived in Istanbul. Was that on the Asian side or was that on the European side? So these are going to be very pointed questions. The reason I ask those questions in this way is because I'm trying to figure out the maneuvering from the emotional part of the brain into the rational part of the brain and how easy you can maneuver between those two worlds. While you're in the process of expressing how miserable depression feels, I'll often throw in a close-ended question to see if I can pull you into, a question about Istanbul, for example, because I know that question is going to force you to move to a different part of the brain. And so I'm testing how stuck you are with this emotional piece and how entrenched the depression is. I'm also going to talk to you at a level which is comfortable for you. So part of my questioning technique will be to figure out what level of conversation you are most comfortable at. Some people are very comfortable at a very sort of basic level of conversation. I will shift my position to adjust to whatever level you're at so that it is easier for you to talk to me. That's the whole point of doing that. Some people will come into my office, almost as they start talking, they'll start crying. And they'll just be very emotionally flooded, and they'll just be emotionally expressive. If that happens, and you're in session with me, I'm going to try to see if I can ask questions that'll try to pull you out of that. Because again, I'm not so much worried that you're being emotional. I'm worried about how easy or not it is for you to maneuver between expressing emotion to not expressing emotion. So I'm going to try to see how that flows to get a feeling of how stuck the depression is, for example. On the other hand, this happens a lot with guys actually. They have a hard time expressing emotion. So I'm going to lean the opposite direction. I'm going to try to get them to express emotion more so I could see again how difficult it is for them to express emotion and whether or not I've got to teach them how to be emotionally expressive. Because that's another part of this sort of nudging your way out of depression. Depression has a way of locking you into a pattern, and we're going to try to maneuver that. So at the end of the assessment period, two things are going to happen. One is I'm going to have a pretty clear idea in my head about what's going on in your world right now. So I'm going to know what it feels like for you. I'm also going to know what your life looks like, whether there are financial problems, whether there are marital or relationship problems, whether or not you've got alcohol problems with just where you're living. Some people don't have enough money to buy food. All of that stuff's going to be covered in the initial assessment. At the end of that assessment, I'm going to make a diagnosis based on the information I was given. Typically, I don't spend much time here because of the nature of the treatment I use, cognitive behavioral therapy. It doesn't require the diagnosis to be a key part of how you treat because of the nature of the way the treatment works. So what I next do is I take the information you just gave me and I provide what is the third part. So the first part's the assessment, then a diagnosis. The third part is the beginning of treatment. First part of the beginning of treatment is psychoeducational part. Not that much different than a lot of the videos we've been producing. It's basically to inform the person about how your mind works, how your brain actually works, and what depression really is. And the reason I do this is because I want to get the person to move away from this connection to themselves, as in I'm depressed, to beginning to see that depression is the thing that's happening to them. Depression's sitting out here, they're over here, and depression comes down and sits on top of them and forces them down. And so I'm going to provide a psychoeducational piece using the information they just told me about and show them how that information applies to the way the brain will then use it in order to maintain or develop and then maintain the depression. If there's enough time, I'm going to look at the two key factors in cognitive behavioral therapy are the cognitive part, the thinking part, and the behavioral part, and I'll start to explain how that works. The thing we look for in cognitive side of the house are cognitive distortions. Cognitive distortions are basically the faulty reasoning that you apply to the story you tell about depression, which causes depression to be maintained. The trick of this form of therapy, part of the pathway, is to change the cognitive distortion, right? So change the faulty reasoning to correct that. And if you correct that, that creates a gap between the depression and reasoning. And that gap is what we're going to use to maneuver yourself out of the depression. The last thing I want to talk about is behavioral interventions. These are going to be things you are currently doing or not doing that are actually working against you, working to maintain depression. We talked before that depression wants you to conserve energy. So you may find that a lot of your day is sitting on the couch looking through TikTok videos. We're going to try to get you to do something different. And we're going to start wherever you're at, and we're going to build slowly. People at this stage, what they try to do is they try to take on too much. And the advantage of taking on too much is that you fail and end up back where you started. And so it's actually a way of maintaining depression. The way we start is we start very slowly by creating goals that you can actually do. For example, if you lie on the couch, say 8 hours a day, the trick will be every hour to get up off the couch for 5 minutes. Simple, in a way, but it starts to build a pattern response in the brain to counter the message you already have, which is I can't do anything. Because sooner or later, the evidence is going to be, well, actually, I can do something. People say, they will come in and they'll tell me that. They'll say, I can't do anything, I just sit around all day. But I know the fact that they're sitting in front of me is evidence that they actually can do something. So I know that the story they tell themselves and the actual facts aren't matching up. Then it's a matter of realigning the brain to the actual facts as opposed to the story they tell themselves so that they can shift their belief in the fact that they don't do anything. This concludes what would happen with me if you were to come in for the first session. Virtually everyone does an assessment of some sort. Some assessments, they will give you paper and pencil tests. I could, for example, give you, say, the Beck Depression Scale, which is a 20-item scale, and you would just check off which one applies to you and the degree to which it does. I would score that, and that would give me evidence that you're depressed or you're not depressed. Some people will do those type of tests. I don't particularly do that. I prefer the conversation because I'm getting a lot out of the conversation. We'll ask questions. We'll go through a history. At the end of it, I'll come up with a diagnosis. From the diagnosis, we'll develop a treatment plan, and I will start that treatment by basic psychoeducation. That will conclude the first session. It usually takes about an hour. By the time you walk out of there, most people should feel this. They should feel a bit of hope. They should feel at the end of that story that they come out thinking about depression a bit differently than they went in with it, and they should feel that maybe there's some way out of this problem. That's what I'm trying to create after the first session.
That was a good ending, isn't it? to give hope that it's not really end of the world. You can still cure it. There's a cure for it. And for that, you might need some professional help. Yeah, but you would find that person when you seek for it. So thank you very much, John, for this many detailed information on depression, on the treatment. I believe many people will appreciate these videos on depression. So thank you very much. In order to catch other videos, please subscribe and pull on the bell. Thank you very much. See you on the next video. You were saying so.
So?
No.
So?
So what?
So what?
You love that word, so, right?